Hi everyone. All right, we'll get started. It's right past 7:30 Eastern time. I am Ellen with Sona. For those of you who don't know what Sona is, we have a lot of, Sona users on here, so appreciate you guys joining. Thank you. A lot of premier sonographers and we're really excited about this topic. But for those of you who don't know what Sona is, it's a free and easy way to share selected ultrasound images and clips digitally with your patients. So I'm just going to go into a couple of housekeeping things before we start the presentation and introduce Dr. Shanker, who's an amazing MFM. Um, so feel free to use the chat as you to comment, find things interesting. We can engage with each other throughout the webinar through the chat. But if you have specific questions, we just ask that you use the Q&A box, which is along the bottom of the Zoom screen. You'll see Q&A. So if you post questions there, the presentation will take about 45 minutes with about 15 minutes of Q&A, give or take. So we'll make sure we get all those questions answered at the end. And this webinar will be recorded. We'll send out a recording after, and you will get an email from the STMS about your CME in the next couple of days. So be on the lookout for that. Feel free to reach out if you didn't get anything. And thank you so much for already, popping in where you're coming from. We have people from, coming from all over. So feel free to introduce yourself, tell everyone where you're from, and we love to see all the participation. So with that, I'm going to kick it over to Jen Silva with Premier.
Thank you, Ellen. Good evening, everyone. We are so glad you've joined us for today's educational session. Thank you so much. At Premier Ultrasound Services, we're proud to partner with hospitals, physician practices, and healthcare organizations by providing expert ultrasound staffing, innovative imaging solutions, and continuing education that supports healthcare professionals in delivering exceptional patient care. Today's educational session is titled Cesarean Scar Ectopic Pregnancy and Other Non-Tubal Ectopic Pregnancies, Practical Tips and Tricks. It is my pleasure to introduce today's presenter, Dr. Scott Shanker. Dr. Shanker is a maternal fetal medicine specialist at Beth Israel Deaconess Medical Center and an associate professor of OBGYN and reproductive biology at Harvard Medical School. He is also the co-founder and director of the New England Center for Placental Disorders, an internationally recognized referral center for placenta accreta spectrum and other complex placental disorders, and serves on the fetal intervention team at Boston Children's Hospital. We are delighted to have Dr. Shanker with us this evening and truly appreciate him sharing his expertise on this important topic. Dr. Shanker, thank you for joining us. We appreciate you taking the time to be with us today. I know how busy you are, so it does not go unnoticed. We really appreciate you. And I'll now turn the webinar over to you. Thank you.
Great. Thank you so much. And thank you for that introduction. I think I'm sharing my screen, but Jen, just confirm that.
Yep, I can see
Great.
it. Thank
All
you.
right. I see lots of familiar names in the attendees, so
Yeah.
nice to see people. All right. So just as Jen and Ellen said, we're going to talk about cesarean scar, ectopic pregnancy, and then really two other ectopics, interstitial and cervical. Excuse me, and cervical. Oop, there we go. Here are my disclosures. They have nothing to do with this topic. So five objectives. Identify sonographic features of CSEP and distinguish it from other either normal or abnormal implantation. Differentiate between CSEP and other ectopics. Hopefully, we can go through a systematic approach to an early ultrasound and how we can apply that systematic approach and keeping in mind the various ectopics. And I purposely did not include tubals just because I think we all see those relatively frequently. So I tried to pick the more obscure ones. Recognize the common imaging pitfalls and then incorporate practical scanning tips. Okay, so we're going to start with CSEP. And just a quick word. So if I don't remember how long ago I gave a talk to Premier, but I think at that time probably I called it cesarean scar pregnancy and not cesarean scar ectopic pregnancy. And it was changed purposely to allow for more options for patients who are in abortion restrictive states, recognizing that these are not normal. So putting the word ectopic was an advocacy piece that ACOG and SMFM and ISHWAG and others have done. So this is now what it's called, CSEP. So let's start with a case. So kind of a patient that can show up to any of our offices, 27-year-old G4P2, history of prior two sections. She's 8 weeks, comes in for a dating scan, completely asymptomatic, no pain, no bleeding. Here's her ultrasound. So abdominal ultrasound. Oh, I should have added, sorry. If you have questions, please just put them in the chat. Jem will interrupt me. There's not a great way to make this too interactive. But by all means, I'd rather answer them in real time if it's about imaging or something I said. So here's her scan. A couple things that come into my eyes on this. One is certainly the low implantation here. Is abdominal imaging, obviously. And then the other thing, and I know the sonographers who I work with, we talk about this commonly when we see cesarean scars, is the closed endometrial stripe. So if you think about an 8-week normal IUP, you typically would not see the endometrial stripe still. So I'm highlighting it right here, right? Because that potential space of the uterus is distended. But when the pregnancy is either a low implantation pregnancy or a cesarean scar pregnancy, often the fundus, the upper pole of the uterus, is still collapsed upon itself. That marker has been described as one of the markers for CSEPs or low implantation pregnancies. And I think it is something that often overlooked. Like our eyes go straight to the pregnancy itself, but there's other things in the uterus that can actually key us in whether or not it's normal or not. So here's the same patient's vaginal imaging, transvaginal imaging. Nice picture of an ovary here. So here's bladder. White line obviously is bladder wall. And something that I pay a lot of attention to, and I'm going to stop it in a second. Ooh, we're almost there. Go back. Is as the sonographers who work with me know, I go in and scan patients all the time with them. I want my eyes and their eyes together, and we work collaboratively. But we oftentimes will follow from the anterior lip of the cervix as it goes into the lower uterine segment. And this image, a little bit fuzzy because it was a video, but this is so the cervix is coming here. This is probably internal os right here. It's coming up where my cursor is the anterior lower uterine segment. And then it kind of comes to a point right there where the cursor is. And it basically comes to a taper, and then the pregnancy kind of fills that cesarean scar niche. And really, what we have found is that cesarean scar pregnancy, which is a precursor to placenta accreta spectrum, is really just a dehiscence problem. So it's a uterine problem more so than a placental problem. Placenta got the bad rap for it, but it's really just a poor healing of the cesarean scar, and then either there was a niche or not, and it implanted into that space. Here is that same picture, same patient side by side with some color Doppler. I think you can see the dehiscence better on this image actually. So right here, I'll stop it right about, go back. Right about here. So here, and cervix coming around here. Here's anterior lower uterine segment from the anterior lip of the cervix. And then this is the beginning of the developing placenta. And then right here, and I'm kind of outlining with my cursor, is the wedge shape remnant of the lower uterine segment as it goes into the cervix. And then where that lower uterine segment would continue is now just replaced by developing placenta. On the right panel is with color Doppler. The PRF here is a little bit too low. That's my bad. It should be somewhere around 2.4, or kind of the rule of thumb that I follow is one, just get your aliasing out. So, there's not much aliasing here, but around 2.4 towards the end of the first trimester and second trimester. It is tissue dependent and other things, but generally speaking, about 2.4. And you can see there's more flow, more hypervascularity than you would anticipate in an otherwise IUP. And obviously the location is also not normal. So diagnostic criteria for cesarean scar pregnancy. One is that you need to have an empty uterus, and that kind of makes sense. This is assuming there's not a heterotopic or a set of twins or something like that, a kind of a run-of-the-mill singleton cesarean scar ectopic pregnancy, and that the endometrial excuse me, the endocervical canal is also empty, differentiating from a cervical ectopic. Detection of the placenta, or at least the sac, behind the prior hysterotomy or hysterotomies, depending on how many scars they've had. And then in early gestation, so about less than 8 weeks, oftentimes the gestational sac is actually a triangle shape that was described by the group at NYU, and then it becomes a little more rounded and normal appearing after 8 weeks. And we think that's because it kind of gets tagged into that scarred area. A very thin or absent myometrium. I argue a little bit on this criteria of 1 to 3 millimeters, because 1 to 3 millimeters kind of identifies those at the highest risk for developing the more severe form of cesarean of placenta accreta spectrum, or increase the risk of rupture and certainly surgical morbidity in those who continue the pregnancy. But you can have thicker myometrium and still have a cesarean scar pregnancy. So I wouldn't hold that as a true and true hard, fast rule. This is just one of the criteria that have been proposed. Again, an empty cervical canal differentiating from cervical ectopic. Some kind of embryonic structures. Again, I think similar to those of you who have scanned placenta accreta spectrum in the second and third trimester, the vascular patterns and the hypervascularity is quite robust. And so this is what we tried to avoid, just to be very clear. So this is a patient who had a cesarean scar pregnancy and continued her cesarean scar pregnancy and developed placenta accreta spectrum. And so this is what it will become. And for those of you who've heard me give talks before, I use this slide. This is one of the most dramatic pictures of a PAS case I've ever seen. And just to orient you here, here's her fundus. This is all normal pink tissue. This is her placenta growing through the wall of her uterus. And like I said, it was a dehiscence, and you can see almost a very, very clear line here on the upper pole of her prior scar, right here, a nice clear linear line of where that dehiscence was. Placenta implanted, grew, and then the lower line is somewhere much lower than that. So that's what we're trying to avoid, or at least pick up. This is a pathology picture that I think actually really helps show the dehiscence. This is not a case that I took care of. This is from Utah, actually, that they published in the Green Journal. But you can see cervix is down here. This pink stuff is the placenta. And so if you follow the anterior lip of the cervix, this is they call it bread loafing. This is basically cutting the uterus like a loaf of bread longitudinally. And then the anterior lip of the cervix becomes the lower uterine segment. And you can see it just gone, right? So this white is myometrium, this white is myometrium, and there is just a large gap between the upper part of that scar and the lower part of that scar filled with placenta. And so this is a true dehiscence, true and true. And this is why you see that big bulging later on. But we can see that in cesarean scar pregnancy too. So that was from a hysterectomy specimen in the second or third trimester. This is from a hysterectomy specimen in the first trimester. And so you can see there's very similar features on the outside. You can see lots of hypervascularity. You can see bulging. This is the patient who opted for a hysterectomy after she's had her second cesarean scar pregnancy and just was done trying and done with her fertility and opted for this as opposed to other management. But the features are very, very similar. And so in 2021, SMFM and many other organizations, SRU, ARM, AIUM, ISHWAG, ACOG, came out with this robust PAS document on ultrasound markers. I had the good fortune of being part of that. We have subsequently changed the name. I added ectopic there, but came out with just kind of two very simple kind of definitions. Gestational sac implanted in part or within the cesarean scar, kind of makes sense. And then low implantation pregnancy is located close to the cervix and near the scar. And it's just more of an advanced gestation. We proposed, and this is something that I think, at least in the units that I work in, we do try to follow, and I think we follow pretty much to a T for those at risk for cesarean scar pregnancy. So if somebody has a prior scar and has a lower gestational sac, or the sac just doesn't quite look, towards the fundus, to kind of follow this transvaginal protocol. So I do strongly recommend transvaginal imaging. I know it's uncomfortable for patients, but I do think this is one of the few things that we do in prenatal diagnosis where we actually can have a direct impact on maternal health. And so this is something that we really should try not to miss. And transvaginal imaging is far superior to see that lower uterine segment. Look at the uterus in multiple planes. And so mid-sagittal plane is usually where we start. Again, following the anterior lip up into the lower uterine segment, documenting where the gestational sac is relative to the bladder and the scar. And I can't emphasize that enough. But to do that, you need to have some urine in the bladder. So the other thing that I highlighted there, bladder, oftentimes we'll have patients drain their bladders. I know for NTs, if you're still doing NTs, we have patients come with a full bladder, but really for many other things, we'll have patients come with an empty bladder or ask them to drain their bladder. I would strongly encourage you to, if the patient's bladder is full or partially full, and she's like, I would really like to void, offer transvaginal imaging then, because you at least get a really nice acoustic window. Your imaging is perfect. If it's too full, it will thin out the lower uterine segment and make that residual myometrial thickness look much thinner. But what I typically say to patients is that let me know when you think you can void or when you feel like you need to void, not to the point like you have to go urgently. And then there's probably enough in your bladder that we can do what we need to do. You don't want the bladder to look like it's collapsing on itself. Otherwise, you don't have the proper acoustic windows. And then just like everything, I think sometimes we all forget this, but really magnify the area. So you're looking at the area in question, seeing the patient's rectum posteriorly or anterior abdominal wall anteriorly just isn't helpful, right? So really focus on the area in question in that lower uterine segment. These are two images from that paper, excuse me. And these are just kind of like classic pictures of cesarean scar pregnancies. On the left is just grayscale. Again, I think it does highlight that dehiscence incredibly well, right? That little black space right there is the lower pole of the niche. The upper pole of the niche is right here. Here's the gestational sac, and you can start seeing the developing placenta. I think that's another comment about the developing placenta. So oftentimes, for newer sonographers that come into our unit who are starting to understand our protocols, and I ask them, where do you think the placenta is going to form? And they kind of look at me and, I don't, how can I tell you at 9 weeks? I would push back a lot. And I think you can clearly see that, like, for this one here, this is going to be the placenta right here. Like, very clear. This is the beginning of the trophoblast. You can start seeing peritrophablastic hypervascularity. Here is the membrane. You can start seeing this white area. So if we just kind of really interrogate the imaging, we can see quite clearly what's going to happen. For the cases that look like this, these nearly are 100% going to progress to PAS. We're going to talk about PAS next month. Please join us. But again, that's the beauty of this first trimester imaging, is that we can diagnose in the first trimester a condition that has pretty significant maternal morbidity and even mortality risk. And for patients who are not interested in accepting those risks, offer safe alternatives to continuing them. The other mark of this is showing here is some bulging. And so you can see that the bladder, this is not representing that the uterus is ruptured per se. It's just that because the wall, because of the dehiscence is now filled with the pregnancy, the weakness, sorry about that. The weakness is that it's going towards the bladder. So the forces as the pregnancy is growing is going into the bladder rather than towards the fundus. And that's why you continue to see the collapsed fundal area that we were talking about earlier. Opposed to a low implantation pregnancy where the previous image really was focused in the niche itself, those low implantation pregnancies are like the earliest kind of previas, if you will, although I kind of break some of my own rules. I don't call anything a previa in the first trimester, but if you kind of apply that understanding of what we know, these are kind of just lower implantation pregnancies that are right adjacent to or involving the scar, but not really in that true niche, like in that pocket. Both have risk of developing into PAS. But there is a differentiation between the two. I talked a little bit about myometrial thickness. So this is really blown up here. So similar orientation, though, just to orient you here. Cervix is off to the right. Bladder is above us. We can't even see it here. Here's the developing placenta. And this space between the edge of the developing trophoblast to the serosa is called residual myometrial thickness. It's usually right below the bladder. And measuring that compared to this one, where you can see it's much thinner, right, in this space here, has people have looked at that, and it does make sense because one of the concerns about cesarean scar pregnancy, not only PAS, is uterine rupture. That number is somewhere between 5 and 10%, depending on what studies you use, but they can be catastrophic. Oftentimes patients will certainly lose the pregnancy, not too uncommon, will result in a hysterectomy, significant blood loss, emergent surgery, and I'm sure there's more morbidity and mortality reported with them. And so if we can identify those patients who are going, and one other thing, it also identifies those who, if they continue the pregnancy, are going to have the most severe cases of PAS. Okay, so if you still go back to those old terminology that we use, placenta percreta, that's what these cases would be. We don't really use that terminology any longer. But um, uh, and so if you measure that thickness, you can start differentiating and providing some individualized counseling on what this is going to kind of evolve to later in the pregnancy. And when people have looked at residual myometrial thickness, so this is here, residual myometrial thickness, and compared it to morbidity, okay, so the thinner you are, these were patients who had high morbidity, so hemorrhage, hysterectomy, ICU admission. These are patients who had lower morbidity. You can see those with thinner residual myometrial thickness were the ones with the higher morbidity compared to those with thicker. So you, again, first trimester imaging markers were predicting what's going to happen later in the pregnancy. A very unique thing in prenatal imaging, actually. One of the simplest ways to identify a cesarean scar pregnancy, this was first described again by the group at NYU, Elon Timur Tish, who really was probably made the most contributions of anyone in the field for this topic. He said divide the uterus into fours. Simple. You can do it abdominally or vaginally. And if you have a pregnancy and you go from the external os to the midpoint of the fundus on mid-sagittal image and then bisect that halfway, making 4 even quadrants, if the pregnancy is in the top right quadrant, you have a very high likelihood of this being a cesarean scar pregnancy. It works abdominally. And I would just say aside here, this here is not amniotic fluid. This is blood. And so we see this not infrequently. This was a scan from our unit. And we do see patients not infrequently who have bleeding behind the cesarean scar ectopic that looks like amniotic fluid. And it kind of, if you say, well, this is the amniotic fluid and that means that this is in the uterus. Well, no, this is bleeding behind. And here's your big bulge of your cesarean scar pregnancy in the niche. So just don't be fooled by that. You can see all the echoes there. It's clearly not normal. But it works abdominally if you divide it, and then it works well vaginally, like I showed. And in the study from NYU, what they did is they looked at that cross, that kind of the junction between those two lines, and measured distance from the line to the middle of the gestational sac. So let me just go back for 1 second. So I'll do it transvaginally, it's better. So they said, okay, if it was in the positive direction, we went this way. When the negative direction, we went this way. And then they just plotted them. Okay, simple. And you can see it actually divides really, really well. Whereas if it goes in one direction from the line towards the left, it is more likely to be an IUP. And towards the right, it's a cesarean scar pregnancy. Now, you don't need to measure. Like that I think was from a research study. They were, it was published. They were adding some academic rigor to the paper, and it was a great paper. But I think practically speaking, you can just get that mid-sagittal image. You do not need if you're doing it abdominally, great. If you're doing it vaginally, take the image, and then when you're done your scan, you can put your 2 lines up, and you just write in the room. And I do this with our sonographers all the time. You can say, oh, just divide it into 4 quadrants. It's in the upper right quadrant. Most likely it's cesarean scar pregnancy. Let's start looking for other markers as well. It works really, really well. The other marker that people have described and also is very, very good at predicting morbidity amongst patients who continue a pregnancy is the crossover sign. So on A, it's just an illustration, as you can see, A is normal IUP. B is what they used to call in the niche, so truly kind of in the niche in that scar. And the crossover is the gestational sac crossing the endometrial stripe, okay, crossing the endometrial line, if you will. So crossover 1 is the most severe form. Crossover 2 minus is the next severe form, and then 2 plus is the least the least severe. And these are embedded more not exactly in the niche. And sure enough, if you plot all of these, um, you find those patients who have the highest morbidity if they continue the pregnancy. I get the question often, okay, well, I have a CSEP, but I don't have a heartbeat anymore. Because these do, what has been shown is that cesarean scar pregnancies do have a higher risk of having missed AB. I'm not sure I totally understand why. I don't think anyone's actually ever really explained why, but it is described, and I've seen it myself quite commonly. And so, what do you do? And so, um, that brings you down in this category. So no fetal heartbeat, you really don't need to do anything. And I would encourage when I get these calls, I really encourage the MFM or the OB that's calling me to kind of just sit on your hands. Like if the patient's not bleeding, maybe a little bit of spotting, probably the best thing we can do is just let this reabsorb and don't do anything. And it can take time. If the HCG people do follow HCGs, I think that that's not wrong. If it starts dropping dramatically, maybe offering them a suction here or there. We're not really getting into management all that much. But my point is that it's not an emergency. Okay. And I think there's time for patient to kind of, you know, kind of process her loss and then get to the right person or the right team who feels comfortable counseling. For patients who continue to continue the pregnancy, and I would just add that, we used to say, so when I was in my training, that these would never grow into normal pregnancies, and I think that that's probably as we understand placenta accreta spectrum a little bit better, is that many cases of placenta accreta spectrum actually started as cesarean scar ectopic pregnancies, whether they were misidentified or early on or not. And so I think, although my recommendation is for people to not continue a cesarean scar pregnancy, and I tell them why and talk about the morbidity of PAS, for those who do, there is a rupture risk, like I talked about. There is an antepartum bleeding risk. There is a loss risk, but still the majority, about 70%, will go on to will deliver a live child after 28 weeks. And I think that that's patients really do struggle with that juxtaposition. Now, interestingly, again, we're not going to talk about PAS, although I know I keep mentioning it. Every marker that's been described for PAS, at least these five, which are the most prevalent five. There's some that are a little more nuanced vascular patterns that certainly hold up with PAS. But if you look at the common five, all of them can be seen in the first trimester. And it was one of these papers that actually showed that they not only share common pathology kind of features, but they all share ultrasound features too. So I'm just going to quickly go through them. You can see grade 3 lacunae here. This is the first trimester ultrasound showing grade 3 lacunae, transvaginal images. Here's the cervix, lots of irregular, numerous, um, and multiple, so greater than 2 lacunae. That's the definition of grade 3. Abnormal uterine contour. See this bulge here. Loss of retroplacental hypoechoic zone. This is a later first trimester scan, but right there. Hypervascularity. And in a study out of Eastern Virginia, they looked at cases that went on to have PAS to cases that had prior cesarean scar and a previous time of delivery, but didn't back and looked at first trimester scans, kind of a cool study. If they went back and looked at the first trimester scan, you can see that those that had PAS were much more likely to have the abnormal ultrasound markers in the first trimester than those that didn't. Again, it's kind of supporting an opportunity for us to identify those at risk in the earliest opportunity. Okay, that was a whirlwind of cesarean scar pregnancy. I'm going to take a quick break. Jen, do we have anything in the chat?
We do not have anything right now. I think everyone's just in tune.
All right, great. We're moving on to
Yep.
cervical.
So we're good to go. Yep.
Cervical ectopic. So similar case, right? 32-year-old G2P1, newly pregnant, positive urine HCG, has a little bit of spotting, not uncommon as we all know, no pain, and a history of uncomplicated term delivery. Here is her scan. So she was referred to our unit just for dating. And, we are at our unit, we're very focused on CSP and PAS. And so at first glance, my eyes were like, okay, this is a cesarean scar pregnancy. But what I didn't recognize on abdominal imaging, I'll show you on vaginal imaging, is that this is much lower than what we think it is, right? First of all, this woman did not have a prior cesarean scar, but if she did, our cesarean scar would be somewhere around here. It wouldn't be this low, right? This is her cervix. And so we start seeing some bulging here in the cervix. Here is her vaginal imaging, and what you can see here is that closed endometrial stripe. Here is her internal os right here. Again, this one does not have a prior scar. You can see this ballooning of the endocervical canal with a clear gestation inside. And then again, at my point about the developing placenta, you can clearly see here would be the developing placenta for this little 6-week embryo. So cervical ectopics are far less common. We see, I don't think any unit sees a lot of them. We probably see, I don't know, somewhere between a half a dozen a year, something like that, like not very many. But they have significant morbidity. They are more common with ART, assisted reproductive technology. The risk factors, if you look at the studies, really aren't all that well described, to be honest with you. And there's two types of cesarean scar pregnancy, of cervical pregnancy. I'll go through the two. But some of them focus more on the pregnancy actually implanting in the myometrium itself, like a complete cervical pregnancy, so not in the endocervical canal. Those are incredibly rare, have a much higher morbidity because if those rupture, now you're rupturing out myometrium and could potentially rupture into the peritoneal cavity, opposed to the ones that are implanted in the cervical canal, can have very heavy bleeding and often also have significant morbidity associated to them, but less likely to rupture. More likely, the path of least resistance is vaginal bleeding. And so that's why some of the risk factors talk about endometrial injury or endocervical injury, allowing the conceptus to get into the myometrium of the cervix, the cervical stroma. So here's a partial cervical ectopic. This is something that I think most of us who have seen cervical ectopics are more familiar with. These are, again, below the internal os. So that should be like your first cue. Okay, are we in the uterus? Are we above or below? And then the next is it's surrounded by surrounded by myometrium on both sides, meaning is it in the canal and you have that endocervical canal on both sides and then myometrium, or is it actually in the cervix, like in the stroma, far less common. So here's an illustration. I really recommend you look at this. This paper here is a great primer on all ectopics. I don't know if it's open access or not, but there's a citation. It's really fabulous. It goes through all of them. And then here is a 2D, so you can see closed closed uterine cavity here. Here's internal os, and here's the ballooning of the cervix, and here's a 3D of the same one. Opposed to complete, where it's actually in the stroma of the cervix. That's what they're showing you here, right? Here is the endocervical canal. This pregnancy is in the wall of the cervix. Very, very rare. I think I've only seen one or two of those in my career, where I've seen many of the other cases. These are more, these need to be intervened on. The path of least resistance is going to rupture, opposed to that confined space in the cervix, although still need some intervention, less emergent than the other. So criteria for cervical ectopic, again, you need to have an empty uterine cavity, kind of classic one, right? The gestational sac is below the internal os. Well, that makes sense, right? Now differentiate that from cesarean scar ectopic, above the internal os, implanted within the cervical stroma, or I would add within the endocervical canal. And implanted is an important one. We'll talk about that, why I say that second. That barrel-shaped hourglassing cervix, that you could see that transvaginal imaging previously with a big um, uh, amniotic sac or gestational sac displacing the cervix laterally, a negative sliding sign, so differentiating between a kind of a spontaneous abortion in progress, where if you when you push some pressure with the vaginal probe, you'll see the gestational sac moving, where with this it's implanted, so you won't see it moving. Color Doppler, and then again, thin cervical stroma as it's distended. So here is a negative sliding sky. These are actually very difficult to find. I got it from YouTube. There's the link if you want, just to give them credit. It's actually a really nice video. And you can see here, so here's the internal os. This is cavity up here, okay? This is a retroverted uterus. And with gentle pressure, if this was a an SAB, you would find what happened? There we go. You would find it moves with it, but actually it's anchored to the cervix itself. So negative sliding sign because of the attachment to the endocervical canal. Here is, whoops, sorry about that. Here is the periotrophoblastic color flow shown pretty well. I looked in my own library. I couldn't find much imaging of cervical ectopic. So but you can see that clearly there is color flow within the cervical canal. This is transverse view. Here's Sag. And you can see cervix stroma is where my cursor is. This is all the pregnancy displacing the cervix. Here is the barrel-shaped cervix. So this is a coronal view of the cervix. Cervix is coming all the way around. And here you can see the gestational sac with the embryo right there. Here's another coronal cine. I think shows it nicely. I do think for these, for cervicals, I think oftentimes we're taught to scan in either sagittal or transverse imaging in prenatal. We don't do a ton of coronal imaging. We do, coronal kidneys and that kind of stuff. But I do think utilizing all your orthogonal planes is helpful to understand the anatomy. Basically, what I did was I threw a bunch of diagnostic criteria into ChatGPT, and I said, "Help me make an algorithm for cervical ectopic pregnancy." So this is a ChatGPT based on good data, and it works pretty well. And so I'll leave it in here. Feel free to use it, but it does differentiate between IUP, cesarean scar pregnancies. And again, I would highlight that is it above or below the cervix is the place to start. I'm not going to go through the whole thing. It's available for you to look at. And then similarly, I did the same thing. I think AI can be our friends for some of this, where, differentiating between IUP, cervical ectopic, and SAB in progress, and cesarean scar pregnancy is not uncommon. I do think that one of the kind of pitfalls that I've kind of have learned from is that a patient who has cramping like a miscarriage often is having a miscarriage. And I know that sounds just like, of course, but we'll get a scan and I'll get a consult for someone. Oh, they have a cesarean scar pregnancy. They're having some bleeding, and they're having kind of this ongoing cramping that just doesn't sound like run-of-the-mill kind of first trimester implantation cramping. And then I scan them, and now it's in the cervix. And this was so, their doc captured it when it was at the level of the scar. I captured it the next day, it was in the cervix, and they're having a miscarriage in front of us. Being so fixated on, is this a cervical or is this a cesarean, is important. And there's some the rows in the bottom here put some of the signs together. All right, that was a quick windfall through cervical. Jen, we're still going to interstitial? All right, I said yes.
Oh, yeah. We are still good to go. Yep.
All right, I'm gonna sip
Thanks,
it.
Scott. Yep.
All right, so same patient. These are clearly fictitious. So 32-year-old G2, newly pregnant, a little bit of spotting, no pain, history of uncomplicated vaginal delivery at term. And just before I get to imaging, just the term interstitial and the term cornual oftentimes are used interchangeably. And I think that there is a growing body of expert opinion, I would say, and probably consensus that cornual should really be saved for someone who has an abnormal uterine cavity, whereas the interstitium is the small segment of fallopian tube where the fallopian tube and the uterus come together, and that is an interstitial pregnancy. And the management is the same of what we used to say for those who have cornual ectopics, and whether they were wedged or whether they, got methotrexate or whatever the management was. But most of those were probably interstitial pregnancies. Um, and so here is, again, from that Human Reproductive Open source that I was mentioning, a nice schematic of exactly where that is. And what I like about this actually is one of the signs is the line sign. And what it's trying to show here in this illustration is that the endometrial stripe, the endometrium, can be followed to the pregnancy. Where if you think about other tubal ectopics, that cannot happen, right? So I don't do a ton of GYN imaging at all, but a fair number that you cannot follow the endometrium into the tube itself, but you can follow it into the interstitium because it's where it's joining the tube. And so that's what this illustration is trying to show. Here is that line sign. So here is the endometrium going into this pregnancy. 3D imaging is like perfect for this. So if you're a good 3D first trimester sonographer, like utilize that skill because you will help your team make this diagnosis and look like a rock star. Um, the diagnostic criteria for interstitial pregnancy are here. Again, my disclaimer, I used ChatGPT for this. I gave it a bunch of good data and I said, make me a nice table. But the criteria are similar. So empty endometrial cavity, an eccentrically located gestational sac, very thin myometrium. Most people do use less than 5 millimeters. The interstitial line sign is highly specific, but it isn't seen all that commonly. I do fear that it's not seen all that commonly because you're not necessarily looking for it. You're not following the endometrium laterally. In my experience, it actually is quite reliable. The sac needs to be separate from the endometrial cavity. Absolutely hypervascular, like all the other ectopics we talked about today. And then again, this highlights the role for or the other planes that we don't necessarily think about all that commonly. Coronal, in my opinion, is by far the best here, and a plug for some 3D imaging. So this is not an interstitial pregnancy. So this is an eccentrically located IUP. And we, a handful of times a year, will get a referral for someone who says they have an interstitial pregnancy. And I think our job is to trust but verify. And sure enough, we have certainly, disagreed with people. And if you have thick myometrium all the way around and the gestational sac is surrounded by endometrium, like this is showing, and here is thick myometrium, and here's endometrium all the way around. Here's a nice picture on 3D. By definition, that has to be an IUP, and it's certainly not an interstitial pregnancy. Interstitial pregnancy would be somewhere here, right, where you can follow that endometrium into the tube up in this direction. So, normal IUPs can be eccentric, and that's fine, but it is the surrounding endometrium is critical to differentiating between the two. Comparing interstitial to tubal is also really important because the management potentially is different, right? Tubal pregnancies are usually managed either with systemic methotrexate or surgery, whereas interstitial pregnancies are usually local methotrexate or wedge resection. And so what this image is trying to show is here is that nice line sign. Here's the endometrium coronal imaging falling right into the gestational sac. Here is that on 3D as well. Here's the pregnancy endometrium falling right in. Whereas here, you cannot, the line kind of gets fuzzy, if you will, and this gestational sac is actually in the tube. This is another example of line sign without endometrium surrounding this in a very, very thin myometrium. Another example of a line sign, again, endometrium going right into the sac. This is an older image, obviously. And I think it is helpful for this. I think when I work with our sonographers and when we do accretas, that seeing surgical imaging is helpful to learn, to help understand what you're seeing prenatally. And so that correlation is really helpful. So just if you've never seen what these look like surgically, this is the tube proper coming off down on the bottom. And you can see this is implanted. This is super vascular. You can imagine if this ruptures, it bleeds a lot. The rest of the uterus is like the uterus proper is here. So this is like a bulge, if you will, at that level, the interstitium. And if when I think about what I see on imaging, 2D imaging specifically, in trying to correlate it with what we're going to see surgically or how we're going to manage it, it is helpful. So if this image is helpful, I hope it is. Similarly, I asked our friends at AI to help us here, and so differentiating eccentric IUPs, interstitial ectopics, and tubal ectopics. Again, the line sign is helpful here. The distance from the lateral, the myometrial thickness, and whether or not it's surrounded by endometrium is also quite helpful. And if this table is helpful to you, I feel free to use it.
Dr.
Okay.
Shanker, just to interrupt briefly, sorry.
Yeah.
Courtney was asking a question about if there was an ultrasound sign to know. So I think that previous slide was very helpful. Courtney, please let me know in the box if that answers your question for the different signs. We're also going to have this recorded so that you can reference these charts as well.
Great.
Thanks, Dr. Shanker.
I didn't put the citations on this. I apologize, but they're probably very similar to that other one. That's my bad. But it was all, I uploaded the papers and it gave me the chart. So I can vouch for the content. I think kind of wrapping it all up, transvaginal imaging is key. And I think for those of you who are doing imaging remotely and the doc is not there, I can't emphasize that enough. Like the ability to see, but with the doc not being present is critical. And so please utilize transvaginal imaging. It really is for these early first trimester cases. It really does help us. In terms of CSEP, residual myometrial thickness can really help differentiate and identify those with the highest morbidity. The shape of the cervix can also help us, and where the pregnancy is in relation to the internal os helps differentiate between CSEP and cervical ectopic. And then again, if there's that sliding sign, then it's most likely to be an SAB. Negative sliding sign is not an SAB. The pregnancy should move a bit, and so you will see a negative sliding sign in cervical ectopic. I have relied on the line sign well. Again, in the literature, it's highly sensitive, but it isn't seen all that often. But again, I think if you look for it, you can find it. And again, I just can't highlight enough that this is one of the very few things that OB, MFM, GYN, ultrasound, prenatal imaging can do to really affect the care of the mother. And that is, our number one priority. And so we're very fixated on the fetus and the morphology and anatomy, which is all also critical. But these are one of the few things we actually save someone's life. And so as you're kind of, going through your systematic approach, just remember that, this is an opportunity to really diagnose many critical ectopics. I'm going to put a shameless plug. We're doing this again in about a month or so, a little bit less than a month. We're going to just focus on PAS, which is, something can talk to ad nauseum about on the 11th at 7:30 Eastern. And I think that's it. And we got 10 minutes for questions. Thank you so much.
I don't see any questions. We'll give it a few minutes to see if anybody, so that you can type it into the Q&A box. Any questions? We have a few minutes here. Thank you so much too. This was incredibly valuable. The sonographic signs, the tips and tricks, and everything you went through. The residual myometrial thickness. You said it was supposed to be less than 5 millimeters, correct? Okay.
Yeah. So less than 5 millimeters identifies those at the highest risk for the most severe cases of PAS.
Perfect.
And likely identifies those at highest risk for rupture, although I don't think that that's been really shown all that well in the literature. It's a
Okay.
relatively rare outcome.
Thank you. And then also the tip of the uterus. So the uterus tip that you provided on TA and TV, where you're dividing it with that cross view, was also very helpful to do. Take the TA and TV imaging, and then after the patient has gone, go back into your imaging, and then put the calipers on the images. That's very helpful,
Yeah. So
right?
my friend Colleen has a question here.
Yep,
So
I see it.
yeah, so Colleen, you did hear me right. So about 70% will have a pregnancy after 28 weeks, but they are accepting significant maternal morbidity. So hemorrhage, hysterectomy, risk of ICU, that historically was 5 to 7%. Now it's probably less than 1% with multidisciplinary care. But that's not offered everywhere across the country. And if you show up to a place that doesn't have a team, your risk is certainly higher. So, um, I think they're balancing their strong desire for expanding their family, but their own risk in making those decisions. Hopefully that answered that question.
We have a few more questions coming in. Can you describe myometrial measurements for corneal ectopic?
Yeah, so interstitial pregnancy, we're going to not call it corneal ectopic, but yeah, so it's the lateral, it's the most lateral edge to either the thinnest area of myometrium. So it would be for most of these, it's either posterior, superior, or lateral, right? Because inferior medial is going towards the endometrial canal. So it can be at any one of those points, and it's from the edge of the trophoblastic tissue, so the developing placenta, if you will, or just the membrane, to the edge of the serosa, whatever that measurement is. Less than
Great,
five
thank you.
millimeters. Less than 5 millimeters is classically the number.
And we have two more questions. Were those fibroids on that first surgical picture from Lynn?
Yes. Yes.
Thank you. And then Natalie has a question. With the widespread of using ultrasound in offices by OBMDs for viability, do you find that these types of cases are found later in gestational age or more frequently caught sooner?
Um, Sorry, repeat that one more time.
Yep. With the widespread of using ultrasound in offices by OB/MDs for viability, do you find that these types of cases are found later in gestational age or more frequently caught sooner?
Yeah, it's a great question. So
Mhm.
I I don't think that we are seeing later cervical or interstitial pregnancies than we had been, before OBs were routinely doing ultrasound. I do think we're seeing more progressed PAS than and getting later referrals. And I do think some of that is that many first official ultrasounds aren't until the second, well into the second trimester, particularly with NIPT, and not everyone's getting NTs any longer, that we're missing that opportunity for, a skilled sonologist or sonographer who, is all they do is MFM imaging or OB imaging. So yeah, I think we are seeing a shift in the presentation for PAS cases. And so that would be, cesarean scar ectopics.
Great. We have another question that just came in. Are there similar abnormal HCG rise trends with these examples compared to tubal ectopics?
Yes. Yeah. So that person's getting at that HCG should increase approximately 55% every 2 days. And so um, or double um, the interstitials don't necessarily follow that pattern. So the cervical and the interstitial will oftentimes not follow a normal doubling pattern. The cesarean scar not a very good, kind of way to differentiate.
Dr. Schenker, can you just repeat the last part? Sorry, the
Did we break
connection
up?
just broke up a little bit. Yeah,
Yeah.
thank
So for
you.
cesarean scar pregnancies, the HCG tends to rise normally. For the other ones, they tend to not rise normally.
So there's a comment coming in from Courtney. I had a patient recently that had a very odd implantation in the lower uterine segment. It definitely looked like a CSEP, but the patient never had any prior uterine pelvic surgeries. She did eventually end up having an SAB, but we scanned her for over a week and the sac was in the same spot. It wasn't necessarily low enough to be a cervical ectopic, but it definitely was not a normal implantation.
Yeah.
Let's
Yeah. I'm not I'm not quite sure what to make of that. But yeah, I mean, I think we see, lots of odd stuff.
a human body.
Yeah, right.
Yeah, this is what's great about what we do though in this field.
Absolutely.
And we're getting a lot of thank yous to everybody. As thank you for super informative webinar, great information and images. We have, does ultrasound determine the outcome of all CSPs or do some benefit from other imaging modalities?
Yeah, it's a great
Yeah.
question too. So, um, you know, there was a strong push, and in many places they still utilize MR. But the
Broke up a little.
radiologists,
Yeah, good.
can you hear
Mhm.
me?
I can now.
Okay.
Yep.
It really is an ultrasound diagnosis. And it doesn't prognosticate it all that well, just to be very clear. Like the residual myofascial thickness can be helpful, but we've had patients who have had nearly none and go on to have a 34-week cesarean and had morbidity associated with that because they had big surgery. But, they would say that was probably the right decision for them. And I've seen patients who I thought would do okay with thick wall and, you know, didn't do so great. So it's not kind of a tell all, if you will, but there really aren't many better other modalities. And MRI has not been very well described in the first trimester for CSEP.
Great, thank you. So we're just going to wrap it up here. If anyone has any additional questions, feel free to email Ellen or myself with those questions, and we'll try to connect with Dr. Schenker. Dr. Schenker, thank you so much for this presentation. It was super informative, a lot of valuable information. And as you heard, Dr. Schenker said he's coming back next month. So please register. It's August 11th, and it will be on PAS, which is a very exciting topic to hear about and learn about, especially with you. So we appreciate your time. This was a great webinar. Everyone's in the leaving comments, thanking you so much for everything. And then just as a reminder, in a few days, you will be receiving an email from the SDMS with your CME to download. Thank you
And
so much for everything. And
yeah, one more
Ellen,
thing.
you want to say yeah?
Thank you guys, everyone, for joining. We will have the webinar registration link live probably in the next day or two. But we will email you as well when it's live. So just be on the lookout. Feel free to register for that one as well once the registration link is live. But thank you. And thank you, Dr. Schenker. This is
Thanks,
great.
guys.
Thank you,
All right.
everyone.
Bye-bye.
Have a good night, everyone.
Bye-bye.
Bye.